if the eustachian tube also is working properly. Okay, so understanding the eustachian tube, understanding the mastoid, understanding the tympanic isthmus is very important. That's why I don't like this concept of otology, rhinology, laryngology. I think otology and rhinology, they are very well linked together because you have one very important link, which is the eustachian tube. And sometimes the eustachian tube doesn't work because you have nasal or sinus problems. And if you have nasal sinus problems and you don't treat those nasal sinus problems and you only treat the ear, only perform like the tympanoplasty or a tympanomastoidectomy or a mastoidectomy, you may have problems in the future because the eustachian tube is not working because you didn't treat the nasal cavity or the sinus. So this is very important concept for me to understand. And I always like to show this paper from a friend of mine, Dr. Rafael Monsanto from São Paulo, Brazil. He did a fellowship with Dr. Paparella, which is a very nice guy. And he did this study understanding the size, the area of the tympanic isthmus in people that we knew that have ear disease, that had ear disease, and in people that we knew that didn't have ear disease, normal people. So we could compare the area of these two cavities. So the tympanic isthmus in people, in normal persons, in normal people without ear disease, is much, much more bigger than the tympanic isthmus in people with ear disease. So the problem is not the tympanic isthmus itself. The problem is not the size of the tympanic isthmus probably, but the problem is the size of the tympanic isthmus that is closed by scar tissue, by fibrosis, once you have those problems in those problems. So to understand this concept of ventilation is very nice to understand the middle ear, to understand the mastoid, to understand the gas exchange that we have from these three cavities and from the nasal cavity, and to understand that blockages can generate perforations or can generate retractions that can go and transform itself into cholesteatomas. And understanding this is very important because we can put the ossicles, we can put the gas, and we can understand in a close way all the gas problems and all the gas exchange that we have in the middle ear. So the tympanic isthmus is very important. As you can see here, there is a retraction, a very good big retraction. The eustachian tube probably is working because you can see here a bubble. So once you elevate the tympanomeatal flap, and the first step of any endoscopic ear operation is starting and elevating the tympanomeatal flap, which is actually a very difficult step. And then you can see here the blockages of the isthmus. The posterior isthmus is blocked, the anterior isthmus is blocked, so we need to unblock those isthmus. The ossicular chain is preserved, so we just need to unblock those isthmus to understand the ventilation pathways and to clean. We put like an aspirator and we see the secretions that come out from the mastoid antrum. Of course, because there was a blockage, the antrum would produce secretions, and secretions in an area, stopped area without ventilation, hot, and an area with a blood and a good center for colonization of bacteria, of course, can be a good center of infections. So we peel up the tympanic membrane from the malleus and understand the tympanic isthmus. And then once you open the tympanic isthmus, we will open the anterior part of the ventilation pathways, the tensophore area, tensophore region, and then we can wash inside to see the secretions that come out from the mastoid and also to see the bubbles that come out from the mastoid, which means that the mastoid can have air and can work. And we also can see here the facial nerve, facial recess, we can see the sinus tympani area, and then we can understand the disease. In this case, I cut a little bit the hand of the malleus, the handle of the malleus, because it was too medialized, but still transmitted the sound, and then we close using cartilage. And why do I use cartilage? Because using cartilage, I use seldom or less gel foam in the middle ear, because the cartilage is a very nice and robust tissue to close perforation, to reconstruct perforations. And since I do not use a lot of gel foam in the middle ear, I think I will have less inflammation or scar problems in the middle ear in the future. So to understand the concept of the tympanic isthmus is very nice. This is an endoscopic view, very nice, from a friend, that you can see here. The endoscope is in the eustachian tube. This is lateral, this is medial, this is superior, and this is inferior. This is the cochleariform process. This is the region of the cog. This is the canal of the tensor tympani muscle. This is the tensor tympani tendon. This is the malleus. This is the von Trott space. This is the anterior malleolar ligament. This is the incus, the long process of the incus, and this is the stapes. This is the anterior ventilation roots that goes to the Prusac space. This is closed by the tensor fold, in this case here. This is the tympanic isthmus, and look at the size of the tympanic isthmus, and look at the size of the incus. So the incus is very, very big, and the size of the tympanic isthmus is very, very small. So if you have edema here, if you have blockage here, you can have problems. And this is the posterior isthmus. So understanding these three ventilation pathways is very nice to understand the disease, to understand why some patients have perforation, why some patients have retractions, and to understand the better ways to treat those things to understand. So another video showing here a retraction, and then we understand in the anatomy to understand the blockages that we have here in the isthmus. So we peel off the malleus, the tympanic membrane from the malleus, and then once you remove the tympanic membrane from the malleus, you can understand the ventilation pathway. So this is here the anterior ventilation pathway, which is open. Can you see the tensor fold is open here? This is the tympanic isthmus, which is now open. We are now open more, elevating more and open more the tympanic isthmus, and the posterior isthmus, which is going to be in this way here. The eustachian tube is anterior over there. We can use those instruments to see the tip of the instrument to assure that the ventilation pathway is open. We can go to the tympanic isthmus, and we can understand in this way the ventilation pathway. When we have a disease like cholesteatoma, for instance, why do we have this disease? Why would we have this retraction? So probably there is a lot of blockages here that creates the retraction. So the first step of the operation, big disease, big cholesteatoma, small cholesteatoma, is to always start where the disease starts. So we always elevate the tympanomeatal flap. In this case here, we are elevating the tympanomeatal flap, cutting the posterior malleolar ligament here, which makes like an X with the chorda tympani, and exposing here this region. So the cholesteatoma is in the supratubal recess, in the supratubal area. So we're going to clean this pocket here, this skin pocket of cholesteatoma, having this plane of dissection, very nice, from the supratubal recess, and removing this cholesteatoma from this area, and also removing the blockage that this cholesteatoma is causing. So probably the patient had an infection. The infection creates some fibrosis at the area, and then the skin go inside, and then you had this retraction because you could not equalize the pressure because of the retractions. So even removing the disease and even understanding that the mastoid was not contaminated with the disease, we still wash, we still open the isthmus, we still understand the anterior part and open the tensor fold here. We are now opening the tensor fold. The tensor fold was already open, so we just enlarge a little bit the tensor fold, and we understand if there is more disease in the supratubal area, near the eustachian tube, in the protympanic space. In these areas, of course, not doing a retroauricular incision, and of course, just elevating a tympanomeatal flap. At the end, we reconstruct the defect that we created with a cartilage using the small V to fit in the malleus. We use some perichondrium. I always like to put cartilage and perichondrium, and you have to remember, perichondrium is not skin. So you can put perichondrium over perichondrium, or perichondrium over cartilage. You cannot put perichondrium over skin. And then you understand. But, always there is a but. This theory of ours, I would say like, is not 100% correct. If it were 100% correct, I would have 100% of success in cholesteatomas, in tympanoplasties, in all the inflammatory disease of the middle ear. And I don't. I don't have 100% of success. Why? Because I think this theory is not still complete. It's not still 100% correct. Why? Because we still have a missing link. And where is the missing link? The eustachian tube. We know the eustachian tube exists. We know its anatomy, but actually nowadays we don't know how to treat. Because we have the balloons, we have the surgery that we can do for the eustachian tube, but actually we don't know how to treat. That's the real thing for me right now. So understanding the eustachian tube, I think, is going to be the next step of understanding the ear problems that we have nowadays. So also understanding the physiology of the disease is very important. So for instance, this is a retraction, a small retraction. And you think, oh, a small cholesterol, a small retraction. The cyclic chain was intact in this patient. So we elevate the sternocleidomastoid canal, the tympanomeatal flap, and then we see the blockages here in this one. See? There's a blockage here in the tympanic isthmus, very, very well seen. And then once you have a blockage of the tympanic isthmus, you can understand what is happening. You can understand why the patient had a retraction. So we have a blockage here, very well seen blockage here, the tympanic isthmus. And then you can see the retraction, and you can see the skin here, the cholesteatoma, medial to the cyclic chain. Supratuber recess is clean. There is a fold here, but you can see here cholesteatoma medial to the ossicular chain. When you have cholesteatoma medial to the ossicular chain, it's very difficult to deal, especially if you have an intact ossicular chain, because you have to understand that you have to remove the incus and you have to reconstruct in the future, because if you don't remove the incus, you will not be able to see, even with angle endoscopes, to see what is medial to the ossicular chain. Even if you do a tympanomastoidectomy, even if you do a canal wall down procedure, you will not be able to see, to understand. So we try to clean here using this curved instrument, but of course, you cannot guarantee that you completely clean everything, so you have to remove the incus. Once you remove the incus, you see a lot of cholesteatoma here, medial in the facial recess here, near to the lateral canal, and also in the anterior tympanic space here, because we cut the head of the malleus. So the endoscopes also in the middle ear, when we're talking about the middle ear, can allow you to see those anterior structures in a better way when compared purely and simply with the microscope. So we start to clean the cholesteatoma, start to clean the facial recess here, and we go inside, wash inside with curved instruments, and then we go and see the mastoid to see if there is any remaining cholesteatoma in the mastoid antrum. And of course, if you cure that here, or if you do a big athecotomy, you can see all the way to the mastoid tip. Of course, it's not very smart to do, but you can do all the way to the mastoid tip. You see the sinus tympani, you see the sinus subtympanicum, you can see all those structures, you can drill and clean all those structures, and then at the end, you will reconstruct with cartilage. And in a second time, or in the first time, I prefer to do in the second time, I would reconstruct the hearing of the patient, if the patient wants. Because if the cartilage stays touching the stapes superstructure that you leave over there, and sometimes you leave the stapes, and when the stapes is not completely eroded, the patient will not need a prosthesis, a port. The hearing will be very nice, actually, when you do like this. So to understand this is to understand a little bit. For instance, in this case of a cholesteatoma, the same thing. This cholesteatoma was big, was going all the way to the mastoid tip. So the first step of the operation is to raise the tympanomeatal flap. The cholesteatoma, big or small, we always start where the disease starts to understand what happened, to understand where were the blockages. So in this case, you see also the ossicular chain was preserved, was not eroded. So there is a polyp. We would remove the polyp here of the middle ear, and then we would see also the blockages that you have here in the tympanic isthmus. Can you see? The cholesteatoma actually was creating the blockage. So the first part is to create an athecotomy, and then you would have a plane of dissection between the cholesteatoma and the mucosa of the mastoid. So we remove another polyp. You would remove the cholesteatoma, remove the incus, of course. See here the ponticulus, subiculum, sinus tympani area that is not with cholesteatoma. Remove the head of the malleus. Once you remove the incus, you can remove the head of the malleus. And then clean the disease from the mastoid, clean the sac from the mucosa of the mastoid. Sometimes you have this non-infiltrative mucosa cholesteatoma, and we're going to talk this in the lecture about cholesteatoma. And then you can remove completely the sac, and also you can wash inside. And once you wash inside the mastoid, you see the other part of the cholesteatoma pop out. Remove the cholesteatoma. It's a big cholesteatoma without a retroauricular incision, without a mastoidectomy, preserving as much as we can the mucosa of the mastoid. Just like nowadays we preserve the mucosa of the paranasal sinus, we can preserve the mucosa of the mastoid, not drilling. Sometimes you must drill, but sometimes you just don't need to drill. And then you can inspect with angle endoscopes to see if there is any remaining cholesteatoma inside the mastoid antrum. Also, you can inspect the supratuber recess. You can inspect the anterior tympanic space, facial nerve over there, geniculate ganglia over there, Jacobson nerve over there, region of the sinus tympani, ponticulus, subiculum, sinus tympani area. You can remove the disease if there is disease in the sinus subtympanicum, round window niche, oval window niche, the hypotympanic cells. And you can open also the tensofold area to create this more anterior ventilation route. And also, you can remove the remaining part of disease. Inspect, this is the lateral canal, this is the mastoid antrum, and if you angulate a little bit, you can see all the way to the mastoid tip. You can see the mucosa, it's preserved here of the mastoid, and then also you can remove the cholesteatoma, remove the cartilage, and then reconstruct the cartilage, making the cartilage to touch the stapes. And if the cartilage stays touching the stapes, if you put the perichondrium and back the tympanomeatal flap, and as you can see, we use a very few gel foam, you can have a very good conduction system for the hearing and a very good functional system, functional surgery for the cholesteatoma, because you see, you preserve the mucosa, the mucosa of the mastoid, you remove the disease, and also you improve the hearing, or you don't have problems with the hearing, and you see the hidden areas. You see sinus tympani, you see facial recess, you see the most anterior tympanic space. But of course, sometimes you have infiltrative matrix cholesteatoma, and those cholesteatomas sometimes, even if they are small cholesteatomas, they kind of stick into the mucosa, kind of stick into the bone. Sometimes we try to wash, they don't come out, they don't pop out like the previous cholesteatoma. You have erosion of the bones, especially the stapes. These are infiltrative matrix. But with endoscopes, you can clean the oval window niche, you can clean the sinus tympani area here, you can clean the sinus subtympanicum here, and you can put a microscope to do a combined approach, a mastoidectomy combined with an endoscopic middle ear work in order to remove completely the disease from the middle ear, which is done with the endoscope visualization because it's better, and to remove completely the disease from the mastoid, which is done under microscope visualization, which is better. You have the second hand, the suction, you have things to work and in a better way. And this is good because since you start the surgery using the middle ear as the first part of the surgery, you already know the position of the facial nerve. So before the surgery, if you know the position of the facial nerve, because you see the facial nerve using the endoscope, it's much more safe to you to drill the mastoid, knowing already where the position of the facial nerve is. If you start the surgery with the retroauricular approach, as traditionally it is done throughout the world in the majority of the centers, you don't know where the facial nerve is in the beginning. You guess where it is, but you don't know. And you use a drill. That's why probably you need a facial nerve monitoring to have more safety. But if you know already where the facial nerve is, you don't need the facial nerve monitoring. So it's a cheaper surgery for you because you already know the position of the facial nerve and you don't need to rely on an equipment which costs money in order to understand the position of the facial nerve. Okay, so understanding the blockages, you can understand the pressure changes, and you can understand the perforations, and you can understand also the retractions, and understand also the cholesteatoma. And guess what? The cholesteatoma pathway, when the spread of the cholesteatoma goes using the middle ear and the mastoid as conduits, follows most of the times these ventilation routes that we talk about. The anterior isthmus, the isthmus, the tympanic isthmus, and the posterior isthmus. So it's very important to understand this, to understand these ventilation pathways. We talked about the immunological. It's very nice because when you cross from the eustachian tube to the mucosa of the mastoid, you see a different change of the mucosas. In the eustachian tube, it has more immunological tissues. You see here those lymphatic tissues that we call the TODs. It's tube-associated lymphatic tissues, When you go to the middle ear, it's a kind of different respiratory mucosa with mucociliary clearance that goes all the way from the mastoid through the eustachian tube, cleaning the middle ear and putting the secretions to the eustachian tube that go to the nose. And the mucosa of the mastoid, a much more respiratory mucosa that has a lot of gas exchange possibilities and capabilities, but has less immunological compounds. Almost no immunological cell here. That's why when you have bacteria in the mastoid, you can have biofilms, and then you can have chronic infections in the mastoid. And it's difficult to treat, of course, with oral antibiotics, even IV antibiotics, because a lot of blood doesn't come to the mastoid mucosa, and the mucosa itself doesn't have, differently from the mucosa of the nose, doesn't have a lot, and differently from the mucosa of the eustachian tube, the cartilaginous part of the eustachian tube especially, doesn't have a lot of lymphatic immunological tissue. So it's very important to understand. So next time you destroy mucosa, drilling the mastoid, you will think, and you think that you are actually doing something that is important sometimes. Yes?
Okay, can we take some questions, please?
Of course, yes. The first part is important.
Okay, so Dr. Amulya is asking a question. How important is the knowledge of mucosal fold anatomy in endoscopic ear surgery?
I think it's a very good question, and the mucosa, the knowledge of the mucosa folds is paramount for endoscopic ear surgery, because those folds can block these ventilation pathways and can create perforations in the future, can create retractions, and even if you do endoscopic or microscopic surgery, for instance, a tympanoplasty, if you don't remove the folds when the folds are present, because sometimes you have perforations that have nothing with folds, but sometimes if you have the folds present, and if you have perforations because of those folds, and if you don't take those folds, probably you have reperforations, even doing the most perfect surgery possible. So to understand those folds is very nice, because you can see if the perforation is caused by those blockages or if it's not. And if it's caused by those blockages, you have to remove those folds in order to create big ventilation pathways. The problem is, since the space is very small, you cannot assure in the postoperative care if those spaces that you create will remain open. How do I know that the space that I create will remain open? The isthmus that I create will remain open. I use less gel foam because of that. That's why I use a lot of cartilage to do the tympanoplasty, because I think using cartilage, you need to use less gel foam, and with less gel foam, you have potentially less inflammation or less scarring tissue in the middle ear in order not to block the ventilation pathways again.
Okay, we have one more question from Dr. Rajendra and Dinesh Kumar. Sir, kindly comment on eustachian tube. Any latest studies on the same, such as eustachogram?
Yeah, the eustachian tube is very important. For me, is one of the most important links in the system. But as I told, we know its anatomy, we know its position, we know its physiology but we don't know how to treat. So the eustachian, at this time, the eustachian tube is very, very important, because when you can have problems related to the eustachian tube that are actually nasal problems, and you can have problems related to the eustachian tube which are actually eustachian tube problems, or problems that are actually middle ear problems. So to understand also this makes us, I think, better scientists to understand the problems of the ear. My take on the eustachian tube is, I think we need to understand a little bit better the treatments that we have, because most of the times the eustachian tube doesn't to be open. So when you balloon the eustachian tube, for instance, you open the eustachian tube, but you're ballooning the cartilaginous part of the eustachian tube. Dr. Tarabishi balloons the osseous part of the eustachian tube, which is nice, but you have the carotid over there. But of course, if you open the eustachian tube doesn't have to be open 24 hours a day. The eustachian tube has to open. So there is a very nice group on Stanford in California trying to do some stimulations of the muscles, of the muscles, to try to have like a peacemaker of those muscles to open the eustachian tube when you need to open the eustachian tube, when you need to equalize the pressure in the middle ear. So for down patient syndromes, for instance, or patients who have problems that cannot, tumors in the pterygoid area that have lesions on the muscles, these patients sometimes, most of the times, they have problems in the middle ear. If the eustachian tube is completely closed, you will have problems in the middle ear because you have no way to equalize the pressure. Or if the eustachian tube is completely open, if you have a patent eustachian tube, you also have problems, as you see on patients that have like cancer or had undergone to stomach reduction and had lost a lot of weight in a very fast way. It lost the Ostman fat, and then you can have a patent eustachian tube that can have infections, inflammations, can have hearing problems, and can drive the patient a little bit mad. So I think the eustachian tube will be the next step in order to understand this link between the sinus, nasal cavity, middle ear mastoid, in order to understand better the disease, both in the nasal area, reflux, for instance, that has nothing to do with sinus or nothing to do with ear. Reflux, if you have reflux, sometimes you can have problems of the eustachian tube, and you can have middle ear problems. So sometimes you need to treat the reflux of the patient in order to have a good ear function. So that's why medicine is very nice, because it's always integrated between these specialties.
So do you advocate, so what is the indication to remove the incus in mucosal disease? This is by Sanjeev Kumar.
Yeah. I am the incus enemy number one, the number one incus enemy in the world. For me, if I could, I would remove the incus in every human being. But of course, this is madness, this is craziness. For me, the indications of incus removal is when you have erosion of the incus, and every time, I will confess, when I have a cholesteatoma, I pray for the incus to be eroded, because if the incus is eroded, I remove the incus, I create a big isthmus. It's very nice to do the surgery. You can have a very nice view of the mastoid using the endoscope and the middle ear as a conduit, and not the mastoid if necessary, of course. But if the incus is not eroded, if the incus is not in a different position, if the incus has not problems, we will not remove the incus. We will just remove the folds that can be between the incus and the facial nerve, for instance, closing the tympanic isthmus. But if the incus is eroded or has any problems, I remove the incus. I think it's the good thing to do. It's like the uncinate. The incus is the uncinate of the middle ear. When you have problems, you remove the uncinate, and then you have a good exposition of the maxillary sinus.
So we have another question. So do you do eustachian tube patency test before each surgery, and how do you deal with cholesteatoma in the medial incudal space?
Yes, about the eustachian tube function test, no, I don't, because I don't think the function tests that we have nowadays, they are good enough to quantify the real function of the eustachian tube. I think we still need to progress also on those tests in order to understand better the function of the eustachian tube. And the other question is, how do I deal with the cholesteatoma medial to the
incudal space?
Yes, this is a very nice question. When you have cholesteatoma medial to the ossicular chain, I always need to remove the ossicular chain, even if the incus is normal. As you saw on that case that I presented, the incus was not eroded, but we had cholesteatoma medial to the ossicular chain. So I remove the incus, I remove the head of the malleus, because when you remove the incus, you can remove the head of the malleus, and then you open the anterior tympanic space, the posterior tympanic space, and also you open the tegmen area and the adus adentrum area. So you can deal with the cholesteatoma over there, and then you can remove the cholesteatoma, removing the incus. In this case, is the only case that I have a normal incus, and if I have a normal incus, I will remove the incus when doing endoscopic ear surgery. When doing microscopic ear surgery, this is also very difficult, because you have to go behind the short process of the incus in the lateral semicircular canal, and you go most of the times blindly. You go with the instruments, and you don't actually see what you're doing, and you're hoping that you remove completely the cholesteatoma. Using the endoscope and removing the incus, of course, and removing the head of the malleus, you actually see what you're removing, and if you see, I think for me it's better.
Can you just, when you answer the questions, can you go up and click on the button not to share your screen, that is get off the screen share, so that we can see you. I mean, the audience, there are so many people watching you, so they can actually see you actually. Yeah, that'll be a great thing. Yeah. So we have a few more questions. Should adichotomy be done in every case of mucosal disease in terms of ventilation?
Well, adichotomy is a very nice procedure to perform, and when using endoscope, you don't need to do a big articotomy, because with curved endoscopes you can see a little bit the regions of the region that you want to see. But of course, if you want to do a big articotomy, it's possible, but you will need to reconstruct at the end. And sometimes it's difficult to reconstruct using cartilage sometimes. I do articotomy in a very short way. I most of the time do articotomy when I have mucosal disease, because I open more the pterygoisthmus, but not very big articotomies. Of course, when you have cholesteatoma, it's different. Sometimes you can do big articotomies. But in cholesteatoma, when the cholesteatoma is very, very big, you remove the middle ear part with the endoscope, removing the disease in the sinus tympani, in the facial recess. That is the areas that are difficult using the microscope, and then go to the mastoid using the microscope to do a mastoidectomy. But just going into the antrum and removing the cholesteatoma, not saucerizing the mastoid, removing all the cells, it's different. Now we try to preserve some cells of the mastoid in order to have the system work in the postoperative, in order to have a little bit of gas exchange, because if we preserve some cells of the mastoid, we preserve some gas exchange.
Yeah, you can carry on with your presentation, Dr. Joe. We are enjoying it.
Okay.
Please.
Okay.
So you have to share screen.
Yes. So we are talking about this immunological thing. I'll pass here, this slide here. Yes. But the most important thing, and you because you can say like this, okay, I don't believe on this theory of the ventilation. I have a lot of cases that doesn't have anything to do with the ventilation. I have to remove all the annulation. I have to drill the mastoid, saucerize the mastoid. Okay, don't worry. If you have good results, your theory it's completely plausible. I'm not the owner of the truth. But one thing you cannot say that I'm lying or that's not truth. The middle ear anatomy, when you see it through the endoscope, it's much, much more better to understand and to teach when you show it using the microscope. So the middle ear, the anatomy, to understand the anatomy is the most important. So we see here the left ear. So this is anterior, this is posterior, this is superior, this is inferior. This is the carotid artery, jugular here. This is the malleus. As I'm the incus enemy, the number one enemy of the incus in the world, I remove the incus here. So we have the stapes, the anterior crus, posterior crus, and then you have the facial nerve here, the tympanic segment of the facial nerve. Look, this is the pyramidal eminescence here, and this is the stapedial tendon. This is oval window niche. This is round window niche. This is the anterior pillar. This is the posterior pillar. The space between the subpyramidal space, which is here, and the promontory sometimes is a bridge. And bridge in Latin, it's ponte. So we call this the ponticulus. So the ponticulus is a bone bridge sometimes from the subpyramidal space to the promontory. Sometimes the ponticulus is absent. You cannot see the ponticulus. Sometimes the ponticulus is like a wall, and most of the times it's like a bridge. So you can have bridge ponticulus, wall ponticulus, and absent ponticulus. Okay? Okay. The space between the posterior pillar and the styloid proeminence, which is here, is called the subiculum. So we have the ponticulus here and the subiculum here. The space between the ponticulus and the subiculum we call sinus tympani. And sinus tympani is very important because when we talk about cholesteatoma, it's one of the regions that is more prone to have cholesteatoma. Recurrent cholesteatoma, residual cholesteatoma, because you cannot see just using the microscope. Sometimes you have to do posterior tympanotomy, but even doing posterior tympanotomy is going to be down, or you can do canal wall down procedures. But of course, doing canal wall down procedures, sometimes you cannot see completely the sinus tympani, and you have a canal wall down, which has some limitations. Now, this is the anterior pillar. If you follow the anterior pillar and go all the way to the jugular bulb, you see the funiculus. Funiculus, fin, it's end in Latin, means end. So this is the end of the retrotympanic area, of the retrotympanic space. So you have ponticulus, subiculum, funiculum. Between ponticulus and subiculum, sinus tympani. between subiculum and funiculum, sinus subtympanicum, because it's below the sinus tympani, okay? In the sinus subtympanicum, you have this area here that we call the fustes. The fustes is a very nice anatomical landmark, especially when you have malformations for cochlear implants, for instance, because the fustes is actually the floor of the tympanic scala, the tympanic area here of the cochlea. So the round window is going to be in this position here. The fustes, like a finger, is going to point you where the floor of the scala tympani is. And of course, it's very nice anatomical landmark. When you have here the space between the funiculus and the fustes, sometimes you can have a canaliculus, a tunnel that goes all the way to the petrous apex when the petrous apex is pneumatized. This canaliculus we call the subcochlear canaliculus. That it's the canaliculus that creates the ventilation of the petrous apex. So sometimes when you have disease, cystic disease in the petrous apex, sometimes you can have an infracochlear transcanal approach all the way following the subcochlear canaliculus to the petrous apex. The subcochlear canaliculus is also a very nice anatomical region, important region to understand when you have congenital cholesteatoma, because when you have congenital cholesteatoma, the subcochlear canaliculus, can have congenital cholesteatoma hidden in the subcochlear canaliculus if the patient has a subcochlear canaliculus. And if you don't remove this subcochlear canaliculus, this cholesteatoma in the subcochlear canaliculus, you can have recurrence because you just didn't see and just didn't remove. So this is very important. So ponticulus here, subiculum, funiculum, fustes, and between the fustes and the funiculum, the subcochlear canaliculus. And then you have the posterior sinus. The posterior sinus is a very nice story, because the posterior sinus is this region here from the ponticulus here to the oval window niche. The posterior sinus is actually not posterior and was described by Dr. House using the posterior tympanotomy, of course. The posterior tympanotomy was not developed for the cochlear implant. The posterior tympanotomy was developed to inspect facial recess and sinus tympani when we were dealing with cholesteatoma. When he did the posterior tympanotomy, he could see the sinus tympani here, and posterior to the sinus tympani, when we talk about going through the mastoid, we could see what he called the posterior sinus. But actually, the posterior sinus is anterior, so we changed the name, and in the Anatomical Society, which is in the Netherlands, they change the name, and now it's called the anterior sinus. So this is anterior sinus, sinus tympani, and sinus subtympanicum. So anterior sinus between the ponticulus and the oval window, sinus tympani, and sinus subtympanicum. When you don't have a ponticulus, you can have a direct communication between the anterior sinus and sinus tympani. When you have a wall ponticulus, you don't have communication between the sinus tympani and the anterior sinus. And when you have bridge communication, you have a small communication between the anterior sinus and the sinus tympani. Okay? Okay. So this is very important to understand. And now, when we put this anatomy here at 360 degrees, we can see the differences of the mucosa. It's very nice to understand. See, this is the protympanic space, and here you have the carotid, and you have one anatomical landmark, which was described by Dr. Patel from India, Dr. Nicholas Juflas, which is the protyniculus. I kind of show you later. This is the canal of the muscle, the tympanic tensor tympanic canal. Cochleariform process, which is here, and cochleariform process can be a very nice anatomical landmark for some structures. Superior to the cochleariform process, we will have the region of the geniculate ganglion. Geniculate ganglion is a little bit anterior, but this is the area, the region of the geniculate ganglion. And superior to that, we can have the cog. The cog is the center of gravity of the temporal bone. If you put like a stick on the cog, the temporal bone, if you remove the temporal bone, will not fall any direction, any side. The cog is a very nice anatomical landmark because it can separate the anterior tympanic space to the posterior tympanic space, but sometimes the cog can separate actually the supratubar recess to the anterior tympanic space. In this case here, the cog is here, and it's separating the anterior tympanic space to the posterior tympanic space. So we have cochleariform process, region of the geniculate gangle, cog, anterior tympanic space, posterior tympanic space, supratubal recess here. And the supratubal recess is a very nice area because the matter of the middle fossa comes down in the supratubal recess. So the dura mater descends going towards the eustachian tube here. So here's the region that the dura mater is more low, even when compared to the segment. Facial tympanic segment of the facial nerve, first genu of the facial nerve, second genu of the facial nerve, mastoid segment of the facial nerve. And here now you can see the facial recess, which is not a recess anymore when we talk about this. It's more like a valley when you talk about endoscopic ear surgery. So we have once again ponticulus, subiculum, funiculum, sinus tympani, sinus subtympanicum, anterior sinus here, tympanic segment of the facial nerve, facial recess, lateral semicircular canal, and below the cochleariform process, you have the Jacobson nerve, which is a very nice anatomical landmark also for the cochlea. Anterior, you have the carotid artery. Inferior, you have the jugular bulb, some hypotympanic air cells, and between the fustes and the funiculus, you have the subcochlear canalicus whenever the subcochlear canalicus is present, whenever the petrous apex is pneumatized. So we have a very nice 360 degrees anatomy of the middle ear when we talk about the endoscopic visualization. Of course, you have different types of anatomies and different types of configurations. So nowadays, I like to say that we are not on the microscopic or on the endoscopic era of ear surgery. We are on the modern era of ear surgery. That can be totally microscopic. So if we have good results with the microscope, only the microscope, okay, keep doing with the microscope. You will keep having the good results that you have. But also, people can have good results or excellent results or even results that are better than the microscope using only the endoscopes. But I really think the best results are going to be when people use both instruments together. To clean the middle ear using the endoscope is easier and less destructive than to clean the middle ear using the microscope. Of course, you have limitations. You lose the second hand. You don't have the suction in the second hand because you have to hold the endoscope, but can overcome this with instruments or with ways to deal with the blood. But of course, when you have this endoscopic assisted microscopic surgery or microscopic assisted endoscopic surgery, for me nowadays is the gold standard of ear surgery. That's why I call the modern ear surgery era, the era of the combined approach, the multidisciplinary teams, the multidisciplinary approach treating the ear and the nasal cavity, for instance, because they are connected, trying to understand more the eustachian tube, trying to understand more those things. So nowadays, endoscopic ear surgery is not more fiction, but more a fact. Many people is doing endoscopic ear surgery throughout the world and having excellent results, even when compared with their own results using microscope-only approach. To understand the anatomy and to teach the anatomy, especially the middle ear anatomy, using the endoscopes, for me, it's much easier because you can see better the middle ear. To understand the physiology, to understand all those things also is easier because you can see better. And you can have better results. You can improve your results when you combine or when you do surgery, preserving the anatomy as much as we can, but doing a kind of a functional surgery. But, and there's always a but on this story, endoscopic ear surgery is more difficult than microscopic ear surgery. The learning curve of endoscopic ear surgery is much more difficult. You have more problems to learn how to work or how to operate using just one hand in such a small space as the middle ear or as the mastoid. And the most important problem that we face nowadays is we have a lot of excellent microscopic ear surgeries throughout the world. People that operate using only the microscope and probably have never held the endoscope in their hands in the last 10 or 15 years because most of them, they don't do sinus surgery. But those guys, they have excellent results and they can do excellent surgeries using the microscope. Of course, they sometimes need to destroy more bone, but they have good, excellent results. The problem is sometimes they want to do in their first endoscopic surgery the same things that they do with the microscope, but over with the experience of their career. So the first endoscopic ear surgery that they want to do, like a big cholestatoma or like a neuroma, like a thing like that, of course, they will not be able to do because it's more difficult to do endoscopic ear surgery. And then they can frustrate each other. They can say, oh, I cannot do this, but I can do this with the microscope, and I cannot do this with endoscope, so the endoscope doesn't work, or the endoscope is not a good instrument. So next time you see a person criticizing endoscopic ear surgery, you have to ask yourself, can this doctor hold an endoscope in his hand? Can this doctor perform endoscopic ear surgery? Because if he can't, probably this criticism is not going to be very well. So it's to understand this, is to understand the politics of endoscopic ear surgery that we have nowadays in the world. And to really become a great teacher or to really become a great doctor, if you want to perform endoscopic ear surgery, you have to come back one step behind, come back to your resident days, learn how to hold the endoscopes, learn how to do small procedures at first, tubes, ventilation tubes, and then you go to small tympanoplasties, and then you go to big tympanoplasties, and then you go to cholesteatomas, and then you go to other things, and then you will understand the learning curve of endoscopic ear surgery because it's more difficult. But endoscopic ear surgery is a very nice way to do functional surgery because you restore the ventilation of the mastoid whenever it's necessary, opening the folds whenever you have the folds. It's a surgery of the isthmus. You prevent the recurrence, and also you understand a little bit of the eustachian tube. Of course, we need to understand the eustachian tube. It's going to be the next step. Is the surgery of the hidden area control. You control the hidden area. You control sinus tympani. You control facial recess. You control the anterior tympanic space. You control the supratuber recess, which are areas that are difficult to see using the microscope approach, and areas that are prone to have recurrence or residual disease. And it's the surgery, whenever it's possible, to preserve the mastoid, because the mastoid has a role. If the mastoid didn't have a role, God or Ganesha or Allah would not have put the mastoid in our hands. So I think it's very important to understand it. Sometimes you need to preserve. Sometimes you need to destroy the mastoid. Sometimes you need to drill. But sometimes you need to preserve the mastoid. And when you preserve the mastoid, I think the endoscope is a better tool to allow this preservation of the mastoid, since you can work directly where the disease actually starts, most of the inflammatory disease, of course, of the middle ear, which is the middle ear, the birthplace of most of the inflammatory disease, including the cholesteatoma. So if you are curious about this, there are a lot of books, seal books from Storts. I call this the holy book of ear surgery, which not only endoscopic ear surgery, because it's the book of my friends, Dr. Prezzuti and Dr. Marchioni, Professor Prezzuti and Professor Marchioni from Bologna and from Verona, because Professor Marchioni draws all these drawings and goes all the way from the embryology to the surgeries using both microscopes and endoscopes in order to understand the physiology, in order to understand the disease, and in order to better understand the treatments. So if you are more curious about this, next year in June, from 13 or 15 of June, and Dr. Janakria will be my guest. You will be there because of me. I will sponsor you over there because I want to have your lecture there, because you have perfect lectures over there. And one of the most important things, the keynote lectures will be Dr. Tarabici, which is considered the endoscopic ear surgery, Dr. Dennis Poe, which is doing a lot of eustachian tube work, dilatation with balloons, Dr. Jean-Marc Thomasin from France, which is considered one of the pioneers, Dr. David Kennedy from the sinus, which doesn't do endoscopic ears. He used to do ear surgery, but doesn't do ear surgery anymore. But he is going to talk about the history of endoscopic sinus surgery and all the hassles, all the problems that they had on endoscopic sinus surgery. And Dr. Professor John House from House Ear Institute, that's going to talk about also the history of ear surgery from the microscope to the endoscope, and probably no. And Dr. Janakran is going to talk a lot of things in this Congress. So it's going to be in Boston from June 13 to 15 next year. The first one was in Dubai in 2015. The second one was in Bologna in 2017. The third one will be in Boston. And Boston, it's nice because you can see the Massachusetts General Hospital, the place where they did the first demonstration of general anesthesia in 16 of October 1846. You can see a lot of things because Boston is very historical in America. And the next one will be in Kyoto, Japan in 2021. And 2023 will be in Brazil. So you are also invited to be here in 2023. But next year will be very nice. So I think this was the first part of this lecture. The second part is going to talk about anatomy or to answer some questions. Do you have some questions about this lecture?
Yeah, I have a question actually. When you're talking about endoscopic ear surgery, so now you can, you've stopped the screen share. Now, endoscopic ear surgery, we lose one hand. So, in fact, when we do the microscopic surgery, what happens is that we hold the suction, use it as a counter traction, and then you have a scissors to cut it. But in endoscopic ear surgery, it's more of sort of a pull because you have to slightly give a pull. Do you consider this as a sort of a, I don't know whether to call it as a microsurgical procedure, because a pull is not allowed in a microsurgical procedure. So how do you actually define it? Because principles of surgery remain the same. You cannot pull. You have to, generally do a traction, counter traction. Do you foresee any instruments which are going to come to replace the other hand?
Yes, it's a perfect question, and you are completely right. We do not follow, when we go under endoscopic ear surgery, the traditional microscopic principles because, as you said, we just have one hand. Of course, we are in the beginning of the surgery. Sinus surgery also in the beginning had problems with instruments because we didn't have the correct instruments for doing this. We didn't have curved instruments for the frontal or instruments for the maxillary sinus. Companies are trying to develop some instruments guided by surgeons throughout the world. Some of those instruments are nice nowadays. Some still have limitations. But I think it's a matter of time to overcome this limitation of the second hand. As you, for instance, have like an assistant holding the endoscope, maybe in the future with smaller endoscope, we can have an assistant holding the endoscope or a holder and doing the surgery with two hands. So I think it's not a matter of instruments, microscope or endoscope. It's a matter of visualization. If you can see things, probably you can cut things in a more precise way. You can remove things in a more precise way, and you can have less residual or recurrence disease when you do this. As a phrase on the Endoscopy Museum in Vienna that there's no difficult surgery. There's bad light and bad exposure. If you can expose with the endoscope or the microscope, and if you can put light, we can do a lot of things as you do. You go to places that no humans have come before.
Yeah, that's a good point, actually. So we are evolving in endoscopic ear surgery. Just want to add one comment that on December the 7th, Dr. Daniel Marchioni is coming live like you, and he's going to give a lecture on endoscopic skull-base surgery. This is for all the audience. It's on December 7th at 9:30 Indian time. Now, we have a question from Dr. Amulya, and she's asking if what are the instruments you recommend? What is the instrument set you recommend? What is the size of the endoscope you recommend for endoscopic ear surgery?
This is the most important question of tonight. And please watch December 7th, Professor Marchioni. He is a very nice guy, a very nice human being, and have very nice progresses in endoscopic area. So the question is about how about the instruments? This is very nice because most of us that are in this second wave of endoscopic surgery, because the first wave were in the 80s and the 90s, but the camera qualities were not so good, and we could not do many procedures as we do nowadays. Now we are in the second area of endoscopic surgery. So first of all, most of us that started endoscopic surgery in the second area, we use the same endoscopes of the sinus, which is not originally from the sinus. The endoscopes that we use in the sinus are 4 millimeters in diameter and 18 centimeters in length. These endoscopes originally come from urology. So urology had this endoscope first, and then we as ENTs, we adapted, Professor Messeklinger adapted these endoscopes to do sinus surgery. So we use this 4 millimeter, 18 centimeters. But nowadays, we had the first endoscope that was originally created to otolaryngology, which is the 3 millimeter in diameter and 14 centimeters in length. This was the first endoscope that was created only for ENT. And why is 3 millimeter? Why is not 2.5, 2.7? Why is 3? Because the 4 millimeter endoscope is very nice because you have wide view, wide angle view, just like the GoPro, you have wide angle view. The wide angle view is nice because you can see more in the wide area, but it distorts a little bit the image. The center is nice, but the peripheral area is a little bit distorted. They do the wide angle view because they have a prisma, a lens. That's why, for instance, if you look in a Storz endoscope, you see rod lens or Hopkins 2 lens. This is a prisma that they put over there that can create the wide angle view. The 2.7 or the 2.5 doesn't have this prisma. That's why you have a small view, a small visualization, not wide angle. The smaller endoscope that we could fit the prisma of this wide angle view was the 3 millimeter. We tried 2.9, 2.8, but it didn't work. 3, yes, it worked. So we created this endoscope with 3 millimeter diameter and 14 centimeter length, not to fight with your hands, because you still have the same image quality of the 4 millimeter, the same wide angle view of the 4 millimeter, but with 1 millimeter less, and 14 centimeters because it's going to be nice for the ear and for the sinus. So nowadays, for me, I do sinus surgery, I use the 3 millimeter and 14 centimeter to do sinus because it's 1 millimeter less, so it's better to work, especially in small nose, especially in children, for instance. So nowadays, I recommend the 3 millimeter endoscope, diameter, 14 centimeters in length. But if you have the 4 millimeter, you can start with the 4 millimeter. And of course, when you want to start, you're not going to start with cholesteatoma. You're going to start with small cases, like tubes, small perforation. To do those small cases, you don't need any special instrument. You can do those cases with the instruments that you have nowadays on your basic ear tray. But if you want to do cholesteatoma, if you want to do other kinds of procedures, you will need curved instruments, curved suctions, like a Thomason, which is like a hockey stick, a bigger Thomason, curved instruments. There are currently 3 or 4 sets of instruments of companies. You have Storz set, you have the Grace Medical set, you have Ponetti set from Spigon ENTs, and you have a Medtronic set. So you have different types of sets of instruments. I always recommend not to buy one set, but to start the surgery with the basic tray. As much as you see you need some instruments, for instance, if you need to go to the sinus tympani and you think you don't have a curved instrument, now I need a curved instrument for the sinus, and then you buy like a Thomason, or you buy like a scissor. But one important thing, have a very nice good scissor, sharp scissor to cut, very nice suction devices, and sometimes you can have suction and elevation or cut devices or some instruments. But the most important is to have a good endoscope and a good camera. One important thing is never, never, never do endoscopic surgery with one cheap camera. The one cheap camera, like a Telecam or Striker 1088, one chip, not good, because when you have one chip, you have one chip for the 3 basic colors, red, green, and blue. When you have a lot of blood in the field, all the chip is going to be colored by the red. So you have a phenomenon called the red out, and you don't see anything. And if you don't see anything, there's no advantage on doing endoscopic case surgery. It's better to put a microscope, a second hand with dissection, no blood, and then you see things, okay? So when you do endoscopic case surgery, it's very important. You don't need to have HD camera. If you have, good. But it's paramount. It's important to have a 3 CCD camera, 3 cam, image 1 HD, image 1S, 1288 from Stryker, 1488 from 1588 from Stryker. It's very important to have a 3 CCD. If you don't have a 3 CCD camera, it can be dangerous to start. As a matter of fact, I see a lot of problems when we talk about endoscopic case surgery, and when people send me the video, oh, doctor, please look at this video, comment on this video, I say, it's a 1 CCD camera. You should never do endoscopic case surgery with 1 CCD camera because sometimes it can be dangerous. Use 3 CCD cameras. This is the most important, a good endoscope and a good camera. The instruments you will see according to your experience and according to the cases that you're going to do. But the camera and the endoscope are paramount. Also, the light source. Light source is important to have a good system. Nowadays, you have LED, you have xenon, you have a lot of. The most important, never work with 100% of light source, because you will transmit heat into the cochlea, into the middle ear, and also you can burn. You can burn the tympanomeatal flap, you can burn the chorda tympani. So you don't have a big cavity like the sinus cavity to need like 100% or 80%. You can work with 40% or less of light, because if you do this, you will not have problems of heat, and you will still be able to see in a good way. So 3 CCD camera, 3mm endoscope, 14 centimeters, good light source with less than 40%, and instruments that you will see according to your experience.
Perfect answer. So you're going to continue with the next topic, right? About the next topic?
Yeah, I will show a video. Yeah, I'll show a video of anatomy. Because actually the next topic would be another lecture, but I think we don't have time. So I will show a video of a dissection of anatomy, which is nice. Let me end here this presentation. Just a second.
So just want to invite Dr. Deepak Haldipur. He is the ex-president of AY India. So I'm seeing him on the Zoom. So welcome, sir. Hello. I think you're driving. So,
no, I just got down. I'm enjoying the lecture. I'm totally engrossed in that.
Oh, thank you very much for coming in, sir. It's a pleasure and honor.
This is a very thrilling experience for me. And I'm thoroughly enjoying this whole experience. And I'm enjoying the lecture, the clarity, the picture. It's amazing, Junkie.
Thank you, sir. Thank you for coming. Thank you.
Yeah.
Thank you. Yeah. Thank you, sir.
Dr. Joe, you can continue.
So now, just a second. I will just put here in this, just a second, in this video here of the dissection, which is this one. Yes, it's this one.
So we have a question, Dr. Joe, from Dr. Sanjeev Kumar. You know, Dr. Sanjeev Kumar is one of the leading endoscopic ear surgeons of India. And he has asked, in which situation you would like to sacrifice the chorda in mucosal disease?
That's a very good question. Sometimes when you have mucosal disease, when you have compression of the chorda because of the folds, and when you have compression of the chorda because of the edema, sometimes the chorda doesn't function very well. And of course, you can sacrifice the chorda whenever the chorda is in the middle of the dissection, or actually is part of the web that you want to remove. Most of the times, you don't need to sacrifice the chorda. But when you need to sacrifice the chorda is when the chorda is involved with those folds, is involved with those diseases. But of course, you have always to talk about the patient. But what I see, when I sacrifice the chorda, I ask for the patients which have disease, not autosclerosis patient that doesn't have disease. I think on those patients, the chorda doesn't work very well. So the patients don't complain when you cut the chorda. When you pull the chorda, yes, they complain. But when you cut the chorda, they don't complain about many taste problems. They know the taste is different when you cut the chorda after, but they don't complain a lot. In another way, when you pull the chorda, sometimes you pull the chorda, and then you can have problems, and then people complain.
No, I have a question, Dr. Joe. Chorda tympani, if you see it in just a dry central perforation or mucosal disease, and you cut the chorda, the people do not have a problem. But in a stapes case, you cut the chorda, they usually complain of problems. So, are there any studies comparing the nerve involved in a mucosal disease or in a cholesteatoma versus the stapes cases? What is your comment on that?
That's a good question. Not that my knowledge, there is a study about that. What I see, but in patients, when you have otosclerosis, the normal middle ear, no disease, when you cut the cord, the people complain a lot. But when you have disease in the middle ear, probably the inflammation that you have, the cord is exposed, not the facial nerve, like the facial nerve that's it's in a bony protection. So when you have inflammation over there, or when you have edema over there, sometimes the chorda, I think, in my experience, I would say like this, it doesn't work very well. So people actually don't complain, but I don't see, I didn't look actually for any studies, and that's a good study to perform,
because
to
you see,
compare
dry,
the taste.
You have a dry central perforation, anterior quadrant, dry central perforation. So even then, people say you can just cut the chorda and get away with it. But in a stapes, always you have to preserve the chorda. So I'm very curious to know why it is like that in a COM versus stapes.
Yes, I think it's important, and it's a good idea for a project that we can do.
Okay, please carry on with your lecture, please.
Okay, we have like 10 minutes more.
Hello.
Yeah.
Yes.
Can we speak one question now?
Yeah. Who is it? Please identify yourself.
This is Sanjeev here.
Oh yes, Dr. Sanjeev. Please tell me. Please ask.
In case of mucosal disease, where the posterior space of von Thross is almost fibrous with chorda, in that case, we need to remove the chorda. We need to sacrifice the chorda. What is the way to sacrifice the chorda? How we can do that?
We cut the chorda. We cut the chorda because the chorda, you see, the posterior malleolar ligament comes from the posterior malleolar spine to the head, to the malleus. And then it makes like an X with the chorda. When you cut the posterior malleolar ligament, you have the chorda here, and then you can cut the chorda in that area. If you cut the chorda in that area, you open the posterior space of von Thross. Then you need to cut the chorda in the most anterior part near the malleus, not to pull the chorda, because if you pull the chorda, and then there will be problems. But
so we have to cut the chorda at two places. One at the posterior end and other at the anterior end.
Yeah, because the posterior end goes to the facial nerve. So if you pull, you can have problems in the facial nerve. And the anterior part, you have to cut also, because if you pull, you can have problems of taste disturbances of the patient that goes all the way to the great petrosal superficie and they'll go to the tongue.
Okay, thank you very much, sir. Okay, thank you.
So I go to the video now. Is the screen shared? No, huh? I'll share the screen now.
Share, please.
Yeah. Now we go to the video. This is a dissection. Not this one. Sorry. This is the nasal. This is a dissection movie that I did in Colombia last week. Last week we had a course in Colombia with Professor Rivas in Bogota,
wow.
And this
the
is
quality looks superb. The quality looks superb. What camera is it?
It's an Image 1S from Storz. Okay. So this is a left ear. You have the anterior part. I'll put this here, down here. You have the anterior part, the posterior part, the superior part, and the inferior part. So we have the malleus here. You have here the incus, and you have here the stapes. We already elevated the tympanomeatal flap. Look, this is the posterior malleolar spine, and there was a ligament here, which is called the posterior malleolar ligament. This is the anterior malleolar ligament that was here, that is here still. We did not remove. And see, the posterior malleolar ligament makes like an X with the chorda tympani. The chord is here, posterior malleolar ligament making an X. And this is the cochleariform process. So look, we just elevated the tympanomeatal flap and cut it, the posterior malleolar ligament. You can cut the chorda here, you can cut the chorda here, and then you have more space. But in this case, we didn't cut the chorda. We just elevated here the tympanomeatal flap. And then once you elevate the tympanomeatal flap, you can see already the anatomy. See, we didn't curate anything, just for you to understand the wide angle view of this is a 0-degree endoscope, not a 30-degree. So you can have here the protympanic space, supratubal recess. This is the canal of the muscle of the tensor tympani, cochleariform process, anterior crus and posterior crus of the stapedius tendon, and we can angulate a little bit more to go here to see. I didn't remove any ossicles, so I have the cochleariform process here, and we have the cog here. Can you see the cog in a very nice way? Geniculate gangle region here, tensor fold area here that's not complete, the tensor fold here, and the Jacobson nerve going this direction here. But also we can understand the most important part, which is going to be the posterior part. Look, I told I was going to talk about this. This is the protympanic space area. This is the eustachian tube is going to be in this position here. This is the canal of the tensor tympani muscle. Look, this is the supratubal recess here. The dura mater of the middle fossa is going to be here. And this is this anatomical landmark that was described by Dr. Patel, which is called the protyneculus. The protyneculus is actually the first bone ridge that you have.
Can you repeat that? I'm not able to get you, please. What is that, Ro?
Protyneculus. Protyneculus.
Protyneculus.
Protyneculus. Protyneculus is this first bone ridge that separates the protympanic space from the hypotympanic hair cells. So it's like the aganasi of this area here. The first cell here that you can see. So they call it the protyneculus. So you have this protympanum here, the protympanum, the hypotympanum, and the protyneculus, which is also a good landmark for the internal carotid artery, which is going to be in this position here. So this is the most anterior part. And then the most posterior part, important for us, is to understand the anatomy of the posterior part. So in this case here, see the facial nerve is here, tympanic segment of the facial nerve, geniculate gangle here, anterior crus, posterior crus, malleus, incus, stapes. This is the pyramidal eminences. From the subpyramidal space to the promontory, we have the ponticulus. In this case here, to see the ponticulus is absent. You cannot see the ponticulus. So there is a big communication between the sinus tympani and the anterior sinus, which is here. So sinus tympani is going to be between the ponticulus and subiculum, and anterior sinus between the ponticulus and the oval window area. So anterior sinus.
I have a question, Dr. Joe. I have a question. See, we were all the way being taught that this is the posterior sinus, and now the nomenclature has changed to anterior sinus. Now, now what do we follow now? Because we are confused. When did you change this nomenclature? And what is the article which we have to read for that?
In 2013, we asked for the International Anatomic Society, which is in the Netherlands, to change the nomenclature. In 2014, they already changed the nomenclature. So in the books that we publish, and in the book, in the Italian book, for instance, in the book of our friends, it's already the anterior sinus. So I think in the new articles that are come from this anatomy, which are not very common articles to have of the anatomy of the anterior sinus, they are going to call anterior sinus. But I think it's a matter of time. But it's just a matter because it's actually anterior, it's not posterior, right? If you think about it. Because this is anterior, this is posterior. The sinus tympani is posterior to the anterior sinus. Right? Okay?
Okay.
And then we have here the sinus subtympanicum here between the subiculum and the funiculus. Let's go more with this video. And then see, we didn't curate any, we didn't do a dichotomy, whatever. We just elevated a tympanomeatal flap and look the capability of the image that we can see here. And see the fustes here, funiculus, and between the fustes and funiculum, we have the subcochlear canaliculus. Look, fustes, funiculus, subcochlear canalicus. I don't know if the subcochlear canalicus in this case is present, because I don't have the CT of this patient to see if the petrous apex is pneumatized, because the subcochlear canalicus is only going to be patent when you have pneumatized petrous apex, because it's the way the air goes to the petrous apex. But we have a space here, and sometimes when you have especially congenital cholesteatoma, you have cholesteatoma going inside those recesses, inside those canaliculus, and if you don't remove, you have problems in the future. So it's very important. So I think it's now done, my time.
Yeah, but I mean, we are ready to listen to you. You're doing great. If you have something more.
Well, if you want, I can show more. This anatomy. The problem with my family, because they are waiting for me to go out.
Oh, okay. Then it's okay. But
don't worry, we will have another opportunity in another time.
Sure. Okay, we will do it again. So I think your wife and children are ready to go out. I can even hear their voice. Yeah. So thank you very much, Dr. Joe. It was a pleasure actually to hear you, listen to you, and to see your beautiful videos of surgery and dissection videos. I really thank you. There was a small problem in my Facebook because there were too many entries inside, so we couldn't transmit a little live. But then we're going to record the whole thing and put it on my Facebook. And this is point number 1. And point number 2 is that just for the viewers, Dr. Daniel Marchioni has accepted to give a talk on December 7th. And I'm sure I want to have another talk from you very shortly. I will come back to you. And we will also give you the feedback as to how this talk has been received by the audience. Thank you very much. Dr. John, are you there?
Yes, I am.
Yeah, so Dr. John from Miami, the person who is actually coordinating the whole thing, really a great job, Dr. John. Really appreciate your, your enthusiasm. All 24 hours you're awake whenever I call you.
Well, you have a very active ENT community.
This is less. This is very less, I'm telling you. You see, all the top guys are here, like Dr. Deepak Haldipu, Dr. Sanjeev, so many people are here actually. I'm really privileged to have everybody, and the boss, the Don, is actually restless now. He wants to go.
Okay, thank you very much.
And look,
Thank you very much.
Oh, in my house, what I have.
Oh, wow, that's very good. That's Lord Vinayaka, yeah.
It brings me luck. Very nice.
Thank you very much. And thank you very much, all the panelists. We will definitely have a memorable time with Dr. Joe in the years to come. He's a big name in endoscopic ear surgery. Thank you. And we hope that we'll come to Boston to meet you there in the World Congress. Thank you very much. Have a nice day. Goodbye and good night for some. Good day for some. The whole world is watching. Bye-bye.
Okay, bye-bye.